Right. Hi, everybody. Thank you so much for coming to this evening's webinar. So this is the second one in our series for young adults living with type 2 diabetes. And this session is on medications. Excited to introduce our speaker tonight, who is Sarah, who is a extremely qualified diabetes specialist nurse, and is going to be taking you through the all you need to know about medications. As I said, ask questions in the Q&A and we will answer as many as we can at the end. Sarah, I will start sharing the slides now.
Say morning everyone, but it's evening everyone. So we're going to go through some understanding around medication and why, what the groups of medications, and then the advice we give to your particular group of individuals with type 2 diabetes. Thanks, Fran. Can we move on? Is it moving?
Is that moving?
No, not for me, it's not. And it doesn't seem to be in presentation mode. I can see the slides at the bottom, which is good for me.
Oh, I think that's you are in control. Bear with us.
Oh, right, hang on. I've stopped. Okay, stop. Sorry. I must have pressed the button. See, this is why nurses don't do technology. Sorry, Fran.
That's all right. I was like, I'm pretty sure it is. Right, let's...
That's better. That's better. So, yeah, let's go on for the next slide. Thank you, Fran.
Okay. Let's go. I'll just go to that one, which is just the what I discussed, and then I'll move you on.
Thank you.
No problem.
So the purpose of tonight's discussion is to help you feel more confident and better informed about the medicines used to treat type 2 diabetes. So you get a bit of an understanding how they work, why they're used, and hopefully feel more in control of your health. Okay. So if you were on the webinar last week, you'll have known that we talked about targets. And it's really important that you know and set a target. It's your target. So you have to speak in collaboration with whoever you're seeing for your diabetes to agree that target, set it up, and know that you've got something to work in. Targets are really important. It's a bit like doing your maths GCSE without knowing your times tables. It's that real basic understanding of type 2 diabetes. Thanks, Fran. So when we talk about targets, we talk about HbA1c. Okay, so again, HbA1c is that average glucose that you'll have measured at the surgery or hospital, wherever you go, every 3 months. And it basically measures how much glucose has stuck to your red blood cells. So at diagnosis, when you're diagnosed with type 2 diabetes, we want your HbA1c to be 48 millimoles. In old money, that's 6.5%. Okay, and you may, at this point, if the diagnosis came as a bit of a shock, you may want to consider remission. Okay, and that's something to talk to your healthcare professional about, what Sussex offers in terms of remission pathways. So we want that HbA1c at 48, okay, with or without oral medication. And then as time goes on, we may consider adding a second or a third agent so we can maintain that HbA1c up to 53. Now, when we get to 58 millimoles, that's when we might consider what we call a GLP-1, or it may be insulin, and insulin may be used to treat your diabetes in certain situations. But all this evidence of these targets comes from a lot of studies to show that the better target you have, that the closer to your target, the better outcomes you're going to have long term. Thanks, Fran. So this is a guide from some training I do for healthcare professionals, and you can see there that your target of 48 millimoles is in that green zone. Okay, so do you know your current HbA1c? Do you know what your target is? It may be that you have a higher HbA1c at the moment, so do you need to set an interim target to think, okay, I can't get down to 48 at the moment because that's a big drop, but actually I would like to set an interim target, so where am I going to agree that? And then you go and you look on this chart, and what we definitely don't want you in the red zone. We don't really want you in the orange zone. We want you moving up from this yellow zone through the blue and into the green zone for your HbA1c target. Thank you. And so what does that equate in real life terms? So what we've given you here is a HbA1c, for example, here. I'm just going to try and make my screen big. I'm sure it's big for you. So we've got a HbA1c here. So if your HbA1c, for example, I've got another chart here. Let me grab that. Here we go. So on the back here, see this blue zone here, which is a target, a HbA1c of 53. That means your average glucose, if we put them all in a pot and all your finger pricks in a pot and worked them out, would be around 8.2. So they go up and down in the day. And then what we're aiming for is for your readings to ideally be 7 or below. Okay. Now, when we set targets, if I set a target of, say, 53, which is this blue line here, I would be asking you for a fasting glucose. That means a glucose when you first wake up or overnight of between 5 and 6.5. Now, if you're not used to working with targets or no one set you that, you can look at this from the Pit Stop Diabetes website, which is a free resource which anyone can use, and you can have a look at this chart and see actually where am I now? Where would I like to be? What does that look like on my finger pricking? Okay, thanks, Fran. So to get to target, the first important thing which we talk about on my next webinar, we talk about diet and lifestyle. Okay, that's the pinnacle of diabetes care. Is, you know, you can't outrun a bad diet. You have to look at the impact of your diet and lifestyle on your day-to-day diabetes management. Tonight we're talking about what medications we can use. So we've got lots of different types of treatments. Now, if I explain that, you know, I've got a shelf in my kitchen with all my diabetes medications on, okay, and I've got about 6 groups of medications that I can pick from, okay. On that shelf, which I want you to always remember, will always be insulin, okay. Now, around 25% of people with type 2 diabetes do go on to require insulin. It's not that anyone's failed or that anyone's not done what they should have done. It's just that's the way sometimes you need insulin to manage type 2 diabetes. Our first drugs, if we come around here, these ones work on the liver, okay, and metformin. So some of you might be familiar with metformin. And that works by reducing your glucose, reducing that sugar in your liver. And it's usually the first medicine that people take that's normally offered on our guidelines, okay? Some of you may have been offered pioglitazone, which also lowers the fat in your liver as well as reducing your glucose levels. So both of those are pretty good drugs. Some of you might have been offered something like sulfonylurea, something like gliclazide, or maybe repaglinide. These are what we call the insulin sensitizers. So these make your pancreas work a lot harder. These are the ones that we might use initially if you're very symptomatic to bring your glucose down quickly, but they're not good for long-term use because we want to preserve your pancreas, not kick it further, okay? Some of you would have been offered an SGLT2. We call these the Flozin, so something like dapagliflozin, empagliflozin, canagliflozin. All of those help your kidneys get rid of that extra glucose, okay, and protect your kidneys, protect your heart as well. Some of you may have been using DPP-4 inhibitors, which are things like sitagliptin or vildagliptin. They help lower the glucose and also lower glucagon in your liver. And then probably most of you, if not for diabetes, might have seen in the news around the GLP-1 agonists. These are our weekly injections that we use to treat type 2 diabetes, but you may be seeing them being used for weight loss as well, because the side effects that were found when treating for diabetes was actually the effects that give rise to that weight loss. Thanks, Fran. So before we think about starting medication, think about what I might choose from my shelf. And what I might choose from my shelf would be your lifestyle, okay? Any other health problems. So I might want to choose drugs that protect your heart and your kidneys if you've got those issues. If you're planning a baby, the only thing I'm going to give you is metformin and insulin. None of the other drugs are safe in pregnancy, okay? It also depends how you feel about taking that medicine. If you drive or you have a job that needs you to drive machinery, for example, I don't want to give you anything that's going to give you a hypo, okay? I need to think about the drugs that might help you lose weight and avoid putting weight on, or those drugs that are going to get you to that target, your age. You're all young people, so you know we would probably throw everything in the book to begin with that suited you, because we want to bring your HbA1c down, we want to reduce those complications, and we want to give you that heart and kidney protection as well. Thanks, Fran. Okay, so let's look at the drugs in a bit more detail. So this is metformin, okay? What does it do? Well, it reduces that glucose production in the liver and improves that insulin sensitivity. So it helps make that insulin that you are making a bit more sensitive to the cells. So it works well. It's been around for a long time, so it's quite cheap. And there's lots of different versions of metformin. You might have been given standard metformin, or you may have been given the slow release metformin if you thought you might have some of the side effects, or you just wanted to take it once a day, for example. So the maximum dose that we're going to give you is 2 grams, but we're going to start you on 500 milligrams and gradually build up to that, okay? So we give it once or twice a day with meals. Oops, sorry, Fran. With meals, and say that helps to reduce some of those side effects. Now, the good thing is about metformin on the pros, it has a good effect on the HbA1c. It drops that by up to 22 millimoles. Okay, we don't tend to get any weight gain with it, and it rarely causes hypoglycemia, and it reduces that insulin resistance. So when we talked last week about insulin resistance and that twin cycle hypothesis, metformin's really addressing a lot of that. Okay, now the cons are that you can get gastrointestinal tummy side effects. Okay, so you should start with a low dose, okay, and increase slowly. At least leave it leave at least a week, 2 weeks before you start increasing that. They are big tablets. Some people say they're like horse tablets, and sometimes we see a B12 malabsorption. So if you've been on metformin for a long time on a big dose and you've got symptoms of B12 deficiency like tiredness and things like that, then you need to speak to your healthcare professional about that and see if you need B12 injections. And that's quite a new thing. We don't routinely give B12 to everybody. Okay, what's important is if you're ever unwell, and you have, like what we say, a dehydrating illness, including something where you're not drinking as much if you're on antibiotics, for example, we would say to you, you need to have a drug holiday. Okay, it very rarely causes problems. Okay, and you might have heard of something called lactic acidosis. That's very, very rare, but that's why we say to give a drug holiday if you're suffering that sickness and or diarrhea or any dehydrating illness. So you pause it. So thank you, Fran. So our next group is what we call our sulfonylureas, and I can never spell that, and I've been a diabetes nurse for 25 years, and I always struggle with spelling it. So we say SU. And what this group of drugs does is stimulates the beta cells to produce insulin. So it kicks your pancreas a little bit. So we don't want to use it long term, but it is our first line treatment if you're really symptomatic when you're diagnosed. And when we say symptomatic, it's what we talked about last week, that tiredness, that urinary frequency, thrush, going to the loo a lot, things like that. So it can give symptomatic relief, and we can use it with pretty much everything else on my shelf. Okay. The most common one that you might have heard about is gliclazide, okay? And we start on 40 milligrams, and we can go up to 160 milligrams twice a day before a meal. You've got modified release version of that, and then you've got glimepiride, which is also modified release. If I start somebody on gliclazide, I tend to go for the standard gliclazide, because the aim is I want to get you off it as soon as possible. So the pros of sulfonylureas is that they've got a high HbA1c efficacy. They're going to drop your HbA1c, and they're going to drop that quite quickly because they're going to kick the pancreas and make it work. So we get a rapid response. So it's good for tackling any osmotic symptoms or nudging you down to a target that you feel comfortable with about introducing other medication. Okay. And as I say, we've got these once daily preparations, which are our long-acting versions. Now, the cons of this is because they're making the pancreas produce insulin, you have an increased risk of hypoglycemia. You also need to do blood glucose monitoring, and the DVLA expects you to do that. Okay. You can also put a little bit of weight on it, because if you think that your pancreas is producing a bit more insulin. Insulin is a hormone, and it can make you hungry. So you might see a little bit of weight gain with gliclazide or sulfonylurea. So it's short-term use because it works that pancreas harder, and we want to preserve your pancreas. Okay, thanks, Fran. So this is a drug called pioglitazone. It went out of favour for a little while, but for our young type 2s, it's very good at addressing that insulin sensitivity, and also addressing some of the issues around the fatty liver that we talked about last week as well. So it has a good impact on HbA1c. Okay, it does improve that liver health. Okay, and because it helps by stopping to build up too much fat in your liver, and by doing that it improves your cholesterol. We also see a reduction in blood pressure and also cardiovascular events as well, which is all really important with type 2 diabetes. The cons with this is that you can put weight on, but that's distributed more evenly. So instead of it all being around your organs, it's distributed all over. Okay, and you might get fluid retention, and with women over the age, well, women and men, there is an increased risk of fractures. So I tend to say postmenopausal women and say 55, and that age I apply to men as well. So I'm not going to use it for our older population. Also, we have to be careful because there's reports of bladder cancer again in an older population. So, and we need to be careful if you've got any problems with your eyes, we're not going to use it. And if we're going to start on pioglitazone, we start on the 15. The maximum we're going to go up to is 30, because we know that the 45 milligrams can lead to a higher risk of those problems. So we stick with the 30 milligrams. But it's a good drug, and it's a good one to put in after metformin. Okay, thanks, Fran. So SGLT2 inhibitors are one of the new kids on the block. Okay, and these are being thrown about like Smarties at the moment, because again they were developed for type 2 diabetes, but every drug that comes to market now has to have evidence to say that it either protects against heart disease or kidney disease, or it doesn't make it worse. Okay, so when they did those studies, what they found is that actually these are good drugs for people who haven't got diabetes but have got some renal dysfunction or some cardiac problems. So you'll see people without diabetes on these drugs being used by heart care teams and kidney teams. Okay, so but we have to be careful with it. Okay, and I'm very, if you're on this drug, you have to make sure that you've been given the right information around it. Okay, because what it does, instead of the kidneys flushing out loads of glucose, but what it can't flush out, it sends back around the body. This drug kind of, I would say, for want of a better word, opens that valve and lets all that glucose out. Okay, so the pros of this is that it lowers your HbA1c because it's getting rid of all that extra glucose that you don't need. You get some weight loss up to about 3 kilograms. And we also see a reduction in this abdominal fat, the stuff around our organs, and it offers that heart and kidney protection. Okay, so it's a bit like an insurance policy. It doesn't cause hypoglycemia, and it also reduces your blood pressure. And the reason it doesn't cause hypos is because it's insulin independent. If you've eaten something, it'll work. If you haven't eaten something, it'll work. Okay. Now, because it's chucking out a load of glucose, okay, you need to think of that like concentrated Ribena. Okay, your concentrated squash that you get. So if it's got a lot of glucose when you're peeing out, that can lead to urine infections or thrush. Okay, and because of that, you have to drink more. An extra glass of water in the morning, an extra glass of water in the evening. Okay. This is definitely a drug that you would pause during illness, that dehydrating illness. Oh, it's gone. Or before you had surgery. Okay, you can't be nil by mouth on this drug. Okay, and if you're following a really low carbohydrate diet like the keto diet, it's not a good drug to be on because of that risk of diabetic ketoacidosis, which can be quite serious. So when you read the leaflet, it'll tell you all about that, but the way to avoid it is to make sure you drink plenty, make sure you have some carbohydrates in your diet, and that you're not from a really strict keto diet, and that you pause it if you're ever unwell. At the moment, it's expensive. Okay, we have to be careful in those people with foot problems, and Fournier's gangrene is not a very nice thing. It's sort of, it's like it starts off as a rash in the groin, genital, perineum area, and it can spread very quickly, and it's not nice. So it's because some people are more prone to that. So it's important, if you're on this drug, that you're drinking plenty and being really good with your hygiene. Okay, so it's not good for elderly incontinent people, for example. We can't use it in pregnancy either. Okay, thanks, Fran. So the ones that you're probably interested in or probably heard about is the GLP-1. So the GLP-1s, which are the injectables, fall under incretin hormones. Okay, so when you eat something, if you've just had your tea and you've just joined, your gut releases incretin hormones. And these hormones help you feel full after a meal and stay full for longer. Now, in people without diabetes, they also help the body release insulin, which lowers blood sugar. But people with type 2 diabetes often have less of these hormones, or their bodies don't respond to them as well. Okay? Added to that, you've got hormones that those hormones are then broken down by an enzyme called DPP4. I don't know what the real name for it is, it's DPP4. Okay? So the hormones, the incretin hormones, also affect glucagon, which raises blood sugar. So together, these hormones help the body manage sugar levels after eating, but we've got less of them with type 2. Okay, thanks, Fran. So remember that DPP4 enzyme is destroying our incretins. Okay. So this group of drugs inhibit the DPP4, okay? So again, when we eat our food, our stomach and gut start breaking it down, okay? And then that triggers your gut to release those GLP-1s and GIPs, those incretin hormones, okay? They help control your blood sugar. But unfortunately, here, the old enzyme called DPP4 comes along and breaks down these GLP-1s and GIPs, so they don't last very long. So what happens when we give this inhibitor is it stops this DPP4 breaking down this GLP-1. So in the lab and on their trials, very clever drug. What a brilliant idea. Okay, because in theory, this means that the hormones are staying around and active for longer. Brilliant, okay? In practice, not so much, okay? And if we can have the next slide, Fran. So you can see that these, we call these gliptins. Now, on the HbA1c impact, you can see that we're only dropping that HbA1c by up to about 9 millimoles. So if you've been given this drug and you're more than 9 millimoles above the target that you're aiming for, it's really not the drug for you, okay? And I would go and ask for something else. It does potentially give a bit of weight reduction. It is well tolerated because it doesn't really do very much, okay? But we have to be careful with pancreatitis. We can't use this if you've had a history of pancreatitis. Sometimes causes joint pain, especially in the elderly. And remember I said about those studies, this does not give cardiac or kidney protection. Can't use it in pregnancy. So can you see that on my shelf of drugs, there's some that I might be putting back, actually, that aren't right for our young adults with type 2 diabetes when we want to protect you long term and we want to get you to that target HbA1c. Thanks, Fran. So along come the GLP-1s and GIPs, okay? So these you would have heard of these, I'm sure. So these are the weekly injectables that help reduce your appetite and help you lose weight. So each one that comes has better effects than others, okay? So the latest one that we've got that you may have heard about is Mounjaro, okay? And now these are diabetes drugs. So if you want to use these drugs for diabetes, we're not going to use them in the same way that we do if I was running a weight loss clinic, okay? Because I'm going to go a lot more slow with diabetes than I am with weight loss, and that's the right thing to do. So all the horror stories in the papers around weight loss medications, it's not the medications, it's the way it's being used, okay? So we see, look at this, a HbA1 see reduction up to 26 millimoles. That's on the 10 milligrams of Mounjaro. But I've got some patients that have achieved a 26 millimole reduction on 2.5 milligrams. I've got people on 10 milligrams that haven't seen any impact because actually they're almost resistant to these GLP-1s, and there is a small group of patients that they won't work for. Okay. Here's the thing that our weight loss clinics are keen in, up to a 10.7 kilogram loss, and that's on the 10 milligrams of Mounjaro. Okay, but we are seeing it with all of these drugs. Okay. And it's cardioprotective. So not only is it bringing our HbA1c down, helping us lose weight, but it's also giving us a bit of heart protection as well. Brilliant. Now, we can't use it if you've got a history of pancreatitis or active gallstones. And this is where some of the horror stories come around weight loss clinics where then people aren't screened properly, or they're not admitting that they've had pancreatitis or gallstones, okay, or they've gone up on the dose too quickly. Okay, we do see some GI side effects, okay, around 10%, but they're usually only when we're starting or when the dose is increased on those GLP-1s, and they tend to be transient and reduce after that. Okay. Now, if you're thinking this might be the drug for me and I need to go and chat to my healthcare professional about it, your healthcare professional may ask you to do some structured education courses around what diabetes is. If you attended last week, that's a lot of what we go into. Okay, they will also make sure that you're attending your eye screening, because if we drop the glucose too quickly, then it affects your eyes. Remember, the eyes don't like changes. So you have to have your eyes photographed and your retinal screening done before we can consider a GLP-1. It can't be used in pregnancy either. So if you're planning a pregnancy, you've got to wait until you've had that pregnancy, delivered a safe, healthy, bouncing baby, and then consider a GLP-1. Okay. But that's the newest kid on the block that everyone's raving about. Thanks, Fran. So if we're going to start a GLP-1, okay, it's not for people with type 1 diabetes. Okay, so you have to rule out type 1 diabetes. You can't use it if you've had a serious condition such as pancreatitis, and we have to be really careful if you've got gallstones. Okay, if you've got those very high levels of fat in your blood, your cholesterol, called triglycerides. Okay, if you drink a lot of alcohol, or you have serious stomach or gut problems. You must have that eye check before starting the medication. And if you have eye problems related to diabetes, you might be asked to delay this treatment, and I might get something else off my shelf until we feel safe that it's okay to take that GLP-1. Okay, thanks, Fran. So what they'll ask you on a GLP-1 is that to start it, you should have a BMI of 35. Okay, because that's the criteria as it stands at the moment. That might change. Okay. Now, what they will ask you to do to stay on the GLP-1 is to achieve a 3% weight loss. Okay. So if we look at this, and we can't forget that this role of weight in diabetes, okay, if you just lose 5% of your body weight, you are already shifting that fat out of your liver. Okay, so that means 100. If you're 15 stone 10, okay, that means a drop to 14 stone 3. So about a stone and a half. Okay, 10% is about just over 2 stone. Okay, or just about 2.5 stone. Okay. The reason NICE asks for 3% for GLP-1s because they know it's hard, and they give you 6 months to do that. Okay, so that's where this comes into play. Okay, so we can't forget the role of weight in diabetes. So the best treatment for managing diabetes is keeping that healthy weight, eating a balanced diet, and being regularly active. Okay, the tablets aren't a magic wand. Okay, we need to think about this triangle as well. Okay, Fran?
Yeah.
Any questions?
Let me stop sharing that and have.
I think I saw one around the GLP-1s asking about, you know, what BMI means. So
Yeah.
basically that's your body mass index. So you can calculate it on an NHS calculator. Your GP will have a record of it. And the reason they set that BMI status to 35 at the moment is because we're going to see more significant weight loss. Now, that 35 can be negotiated with certain people in certain jobs, or if you're of an Asian or ethnic minority. Okay, but you really do need to speak to your healthcare professional about that to see where you want to go with it. Okay.
Yeah. Okay. Another question's come through about kind of, are there long-term effects, or are there any things that we should be worried about if we're starting these medications at quite a relatively young age? That obviously, you know, some people don't start these medications till 65, something like that. If you're starting at 35, does that have any implications?
No, the biggest impact is your HbA1c. So you've got to keep your HbA1c within that target as much as possible. And that's why we say that health, diet and lifestyle is the top of that triangle, but you use appropriate medications to help you achieve those three things, that diet and lifestyle, that healthy weight. But it doesn't, you know, the long-term data, especially for some of the newer drugs, is indicative that it's cardio and renal protective. Whereas some of the older drugs like sulfonylureas, we don't want to use long term because they don't give that cardio renal protection, and they do work your pancreas a bit harder.
Right. Lovely. Okay. Thank you, and thanks everybody for joining. For everyone who is watching this back, thank you for watching it back, and we look forward to seeing you next week for pregnancy, for those who it is relevant to, so pre-pregnancy planning and pregnancy with type 2 diabetes. And thank you very much, Sarah, for your insights and wisdom.
Thanks.